Good afternoon, dear colleagues. And I would like to thank the organizing committee for inviting me once again. It is a great honor for me to present once again this meeting, and I really apologize for not being able to be with you today. My talk is on novel therapies for small cell lung cancer. These are my disclosures. Small cell lung cancer accounts for 15% of all lung cancers, and it expresses neuroendocrine features and presents as malignant, epithelial, high-grade neuroendocrine tumor, quite often expresses TTF1 positivity. Since 1950, small cell lung cancer is classified using the two-stage classification system by the VALG and is divided in limited and extensive stage disease. More recently, we use the TNM system. Limited disease is a disease that can be confined in one radiotherapy field, and more of that can be counted as extensive disease. Majesty score is another prognostic score that is very often used in the UK and is calculated by a number of physical and biochemical markers. Since the introduction of cisplatin etoposide in 1985 until recently, there was no great development in the treatment of small cell lung cancer. We all know that small cell lung cancer is an exceptional liver subtype of lung cancer. Its biology is complex and we don't understand it completely. And management options remain limited. Management is really straightforward. Rarely surgery plays a role. Radiation plays a role quite often, and systemic therapy always plays a role in the management of small cell lung cancer. Management is guided by stage. Patients with very limited stage can undergo lobectomy, followed by adjuvant chemotherapy. Treatment of limited stage disease until 2019 was the combination of cisplatin or carboplatin etoposide concurrently with radiotherapy, thoracic radiotherapy, followed by PCI. And for extensive stage disease, again, cisplatin or carboplatin etoposide given for 4 up to 6 cycles, followed by PCI, and quite often with thoracic radiotherapy, depending on the response. For second line, topotecan, paclitaxel, gemcitabine, vinorelbine, and temozolomide have been used with poor response rates. And debate so far was between cisplatin versus carboplatin, irinotecan versus etoposide, amrubicin versus topotecan. Challenges remain the same. The rapid course of onset of symptoms is the most important. We all know that by the time of presentation, patients are very ill. And the limited access to representative tissue is also a problem. We know that most of the times we get diagnosis using fine needle aspirate. And there is a lack of tissue is really hindering the study of small cell lung cancer. Over the past decades, there has been a great activity with trials in small cell lung cancer. Angiogenic have been tested with no benefit. Targeting growth factors and apoptosis also failed. There are only a few targetable, actionable mutations in small cell lung cancer, and biomarker development compared to non-small cell lung cancer is at a primitive stage. We have identified some signaling pathways, and these pathways can be distilled in 5 aspects of cancer biology: immunotherapy, cell cycle, developmental regulatory pathways, epigenetics, and DNA damage and repair are the main areas for research. What is the rationale of using immunotherapy for small cell lung cancer? Small cell lung cancer has a high number of somatic non-synonymous mutations. It is related with paraneoplastic syndromes, and it induces an immune suppressive phenotype. Therefore, immunotherapy has been checked in pretreated small cell lung cancer patients. Checkmate 032 and Keynote 028 with Keynote 158 are the most important studies at this stage, with median OS 5.6 and 7.7 respectively. We have seen modest response rates, but the landmark survival rates were very promising, and we have seen an important number of survivors in 2 years and beyond. 2 years and beyond. And this one led to the third line monotherapy accelerated approval for both nivo and nivolumab and pembrolizumab. Unfortunately, the confirmatory studies were disappointing. The first one is CheckMate 331. In this study, nivolumab compared to topotecan. And unfortunately, nivolumab did not improve OS. Therefore, has not been approved for this stage. And in 2021, both third-line indication have been withdrawn. And now we're moving on to first-line immunotherapy. We have 4 important studies. First one of them is IMpower 133. In this study, atezolizumab added to standard chemotherapy, carboplatin and etoposide. None of patients received cisplatin, and patients follow maintenance treatment with atezolizumab or placebo. The addition of atezolizumab to chemotherapy increased survival, moving the median OS from 10.3 months to 12.3 months, and the 1 year overall survival increased from 38 to 51, with a hazard ratio of 0.7. Similar good results for the PFS. And this study is the first study over decades now, the first positive study establishing the standard of care for extensive stage small cell lung cancer treatment. If we continue follow up, we see that the benefit on overall survival we observe on the year is persistent and is similar 18 years later, which is extremely important. Another important and positive study came a year later, the Caspian study. In the Caspian study, durvalumab added to standard chemotherapy, or tremelimumab added to durvalumab and to standard chemotherapy. The primary endpoint was OS. And again, we see that the addition of durvalumab to chemotherapy increases OS to a degree that is strikingly similar to atezolizumab. The third arm, the tremelimumab arm, was negative. It seems that the addition of tremelimumab to durvalumab and chemotherapy did not increase survival, but it did increase toxicity. The 3-year overall survival update presented at the last ESMO, and we can see that 3 times more patients are alive in 3 years. So the probability of OS has increased from 5.8 to 17.6, which is almost triple. Another important study is the ECOG-AGREEN study. This is a phase 2 study where nivolumab added to cisplatin to standard treatment of cisplatin or carboplatin plus etoposide. Again, we have seen the same trend of response. There is improvement of survival, but this study is a phase 2 study, and the number of patients is a small number. So the results were not enough to support change of practice and for nivolumab to get approval for this line, but the result was strong enough to support the principle that the addition of immunotherapy to chemotherapy increases survival. Another very important study is the Keynote 604 study. In this study, pembrolizumab added to chemotherapy, and the results are similar with the previous studies. Unfortunately, this study did not met its statistical threshold for significance for survival, missing only by 1 patient. And pembrolizumab again failed to get approval for this stage, for this group of patients. Atezolizumab, carboplatin, and etoposide and nivolumab platinum treatment and etoposide is the standard of care for extensive stage small cell lung cancer in 2022. But where do we go from here? First of all, we need better biomarkers. And there is a lot of research on this issue. Immunotherapy also has been tested as maintenance treatment and at earlier stages. Immunomodulators beyond PD-L1 also have been tested. PD-L1 and TMB, finally, are not good predictive biomarkers. And Rubin presented in 2019 that the expression of transcription regulators defines these tick subsets. And can you use this subset to guide us for the use of chemoimmunotherapy? Probably not yet. But we observe long-term survivals across molecular subtypes in recent studies, especially the one with atezolizumab. What is the rationale of using immunotherapy as maintenance treatment? Is the late separation of Kaplan-Meier curves. OS benefit of immunotherapy emerged at 6 to 7 months after the initiation of treatment. Therefore, nivolumab plus ipilimumab has been tested as maintenance immunotherapy in Checkmate 451 study. Checkmate 451 failed to show OS benefit, and therefore this particular approval has never been given. Moving now to limited stage disease, there are many important studies. Stimuli, Adriatic, Achilles study. Stimuli study is a study with a very complicated design where nivolumab and ipilimumab have been used in limited stage disease. But the Stimuli study did not meet its primary endpoint of improving PFS. CTLA-4 inhibitors also tested in a number of studies, but unfortunately, again, no OS improvement was found. And TIGIT drugs also tested in small cell lung cancer. Tiragolumab added to atezolizumab in PD-L1 high non-small cell lung cancer patients in the CITYSCAPE study, and later on added to a combination of chemotherapy and atezolizumab for small cell extensive stage patients in the Skyscraper 02 study. But recently has been announced that the Skyscraper 02 study did not meet its primary endpoint for OS. This is the latest guidelines for extensive stage small cell lung cancer that we use currently in 2022. There is a lot of clinical trial activity. Novel treatments are currently used for small cell lung cancer and are under investigation. AMG 757, a bispecific T-cell engager immunotherapy against DLL3, is currently under investigation in phase 1 study. A selective Aurora kinase inhibitor, alisertib, is under investigation and is used with a combination of paclitaxel in small cell lung cancer. PARP inhibitors are also under investigation in phase 2 studies. Lurbinectibib is another very promising drug for small cell lung cancer, and although the Atlantis trial did not meet primary endpoint, phase 2 basket trial is running at this stage, and the drug is also on investigation at the maintenance setting with combination combined with atezolizumab. Trilaciclib, a CDK4/6 inhibitor combined with chemotherapy, has got approval from FDA in February 2021. There are many drugs currently tested for small cell lung cancer. And to conclude, small cell lung cancer is an heterogeneous disease. Predictive biomarkers are needed to help us identifying subsets of patients more likely to benefit from immunotherapy and targeted therapies. Clearly, more work needs to be done, and still we have a long way to go. Thank you for your attention.